Order, order. Welcome everyone to this first public session of the Health and Social Care Committee for this Parliament. This is Wednesday, the 20th of November, 2024. We are excited to be up and running and extend a warm welcome to all of those in the room, to our witnesses, and indeed anyone watching at home. Today we will be taking evidence from Lord Darzi, the author of the famed now Lord Darzi report. He's an independent peer and an academic surgeon. With him, we've also got Tom Kibasi here to support. He's the chair of the NHS Community and Mental Health Providers in North West London and former executive director of the IPPR from 2016 to 2020. And he was the senior policy advisor to Lord Darzi for his landmark 2008 High Quality Care for All review. So it's wonderful to have you both with us today. Thank you so much for coming. Now, since the report's publication in September, and Lord Darzi, I don't know if you know this, but it has appeared, or indeed your name has, 127 times in Hansard since its publication. It is the official report of all parliamentary debates, for those who don't know what Hansard is. The report diagnosed the key challenges facing the NHS today. And whilst we appreciate that you are not a minister, and so therefore it is not your job to come up with all the answers, we very much appreciate you being here to give us a bit more insight into the creation of the report, the analyses you did, and indeed some of the conclusions that you started to point at without necessarily reaching firm conclusions as to what to do next. So in that spirit, we will get going. The committee members are very excited to hear from you. If I could start by asking about something I know we share a passion about, which is the data, because this report relies incredibly heavily on data. In fact, over 300 new analyses were commissioned as part of this. Lord Darzi, how difficult was it to get this data? Can you talk us through the process of getting the data on which you have drawn on in this report?
Thank you, Chair. Thank you for having me here. I have been here before in a different context, but it's a great privilege, by the way, to be asked to be leading this piece of work. I have few words to say, and I will go straight after onto the data question, if that's okay with you.
How long are you?
No more than 5 minutes.
Can we make it shorter than that, please?
I will try my best.
We've got 2 hours with you. I'm confident you will get it through.
That's a lot of time
in the 2 hours, indeed. So,
thank you. Well, firstly, it's a great privilege, really, to share the findings of the independent investigation of the NHS. This investigation was conducted with meticulous analysis, and I'll come back to that, and contributions from 75 organisations, which shines the light on the pressing issues facing our health system today. The NHS stands at a crossroads, facing an unprecedented challenges, but also immense opportunities to rebuild, innovate, and thrive. The report makes it abundantly clear the NHS is in crises. Public satisfaction, as we all know, is at a time low, with patients and staff alike grappling with systems that struggles to meet expectations. Frustrations abounds, and that includes me, and this is not just an anecdotal one, it is lived reality for millions really across the UK. Compounding the crisis is the overall decline in the nation's health. That's the bit that I was alarmed most with, particularly since 2010. Life expectancy improvements have stalled, and we now face a heavier burden of long-term illnesses. The social determinants of health, factors like poor housing, income instability, have worsened. These trends have led to increased demand for healthcare services, further straining on an already overstretched system. The NHS's performance is also failing short across critical areas, and I'm going to go through a few of them. Several shortages, severe shortages of GPs, particularly in deprived areas, have driven waiting times and patient satisfaction down. Over 1 million people are waiting for community services, with mental health delays disproportionately affecting children and young people. A&E departments are overwhelmed, with over 60% of patients seen within 4 hours, down from 94% back in 2010. Waiting lists for surgeries are ballooned, with hundreds and thousands of waiting more than a year. In my own specialty of cancer, delays in diagnosis and treatment mean survival rates lags behind comparable countries. Despite all the efforts I could put in as a surgeon in technology, the sad fact is a late presentation is one of the most important determinants when it comes to cancer survival. Cardiovascular care has also suffered with critical treatment delays. Let me turn to some of the systemic issues. Beneath all of these performance gaps lies a systemic issues that must be addressed. One is the budget allocation productivity. Too much funding is directed to hospitals at the expense of primary and community care. And I say this as a hospital doctor, by the way. Productivity gains have not matched staffing increases. The capital investment shortfalls. I work in St Mary's. I'll love to take you around and show you the infrastructure there. Years of underinvestment in infrastructure have left us with outdated equipment, crumbling buildings, and insufficient digital modernization. The impact of COVID-19, exacerbated with pre-existing weaknesses, created larger backlogs and further disruption of services. What about the staff and the patient engagement? Sadly, declining patient satisfaction and low staff morale have become significant concern, and I see it again in the coffee rooms or the canteens. Post-pandemic, we are seeing reduced discretionary effort by many colleagues and high sickness absences among some of the staff. On the management oversight, there's complex management structures, excessive oversight, worsened by the 2012 Health and Social Care Act, which I've mentioned in my report, have created a lot of insufficiencies. While the 2022 Act made partial reforms, and more work remains. So this report offers a roadmap for recovery with 7 key recommendations, which I'm not going to go through because you probably have read them. So that's my starting point. Coming back to the data, we've always, and as a clinician, I've always known that as a system, and by the way, it's the envy of many, we have a huge amount of data. Mm-hmm. You know, from the cradle to the grave, and for a considerable decades of amazing data. Mm-hmm. We've never managed to use that data, and I say this wearing my academic hat. You know, the best to it would have been Brian Jarman, if you remember. He used some data in coming up in his patient safety or mortality figures many, many years ago. So back to this report, you know, when a Secretary of State asks you to do something like this, which was obviously a privilege to make any contribution, and I've worked by the way, both governments, both Conservative government, but also the Labour government, as you said previously as a minister, is, you know, what levers do you have to get this data? More importantly, when he threw the question at me, I would not, fine, I'm happy to do it, but his deadline was 8 weeks. Now, I've never really, I don't know if you knew, I've never done a review of this nature in 8 weeks.
Indeed. It's
a difficult task. It's a big, big ask. The only way you can actually do something like this is to have high quality data. Yep. That's the only way. And thanks to Tom, who is a genius in this area, we asked the department for nearly 330 data sets. And we really wanted to go back to the millennium. We didn't want to do this. What
determined the millennium as your starting point?
2001, essentially, where we got.
Well, there are a couple of graphs from 2000, but why there? Why not earlier?
Well, I think that the data didn't exist.
It didn't exist.
The data sets don't exist because IT systems weren't as developed before then. Okay. So there's some data that precedes 2001, some goes back to 1948 or even before that. Yeah. But most of the data doesn't.
That's very helpful. Thank you.
So that really was the key to solving this 8-week dilemma of how do we get this done. And we tried our best to really come up with sort of hypothesis-based questions and how are we going to address this. And
I was going to ask that. How did you decide which 330 analyses to do? Was it, I've got this question, show me the data, and then what happened?
Well, for us was to look at, you know, what are the big themes? Access themes, quality themes. Mm-hmm. At the end of the day, I'm a clinician. These are the things I'll be looking at. You know, where are we with the different pathways of care? Where is cardiovascular disease? Are getting better? Are we getting worse? Where is I'll come back to stroke services. Maternity was another one. And then we dug deeper. It wasn't just the maternity, it's the workforce element associated with that. So that's really how we picked it up. It's not just the major themes that might be exciting to the public or politicians. I went deeper. I wanted, as a clinician working in the service, I wanted, and an academic, obviously, in many ways, I wanted to learn and see, what could we find from this data. Mm-hmm. And we can go into the details of the data. But I can tell you, no one else could do this. We are so endowed.
No other health service?
No other health system could do this. We are so endowed by this. And we have to use this. There's something you learn as a clinician academic is you can only improve things by measuring it. And if we don't start measuring it, it becomes very subjective discussion. But let me hand over to Tom to tell you a little bit about the depth of the data.
Yeah, I think when it came to the data, we start off essentially with an analytical framework which really maps to the structure of the report. And then there are some things that are kind of more intuitive. So access to care makes sense to measure that by setting. For quality of care, you couldn't measure quality of care purely by setting of care, simply because that would be too high level. So then we took it down to the same pathways that ARA had set out in high quality care for all back in 2008. So you see the pathways of care is how we cut the data on quality, and then looking at some of the biggest killers, so the areas where there are most avoidable deaths. And then for the other parts, which get into questions of cost and questions of productivity, again, those are better understood by setting, partly because the health system is organised by settings of care rather than organised by pathways of care, and therefore it makes sense to interrogate the data for that by the different settings. And that really drove an analytical framework, and from that out came a set of analyses that we specified. And the Department of Health and NHS England did a really remarkable job in assembling that data at such a rapid pace. And I think there are a couple of facts that I think are worth sharing. At the peak of this work, there was something like 200 analysts across the Department of Health and NHS England who were contributing data into the report, so just a colossal team effort. And the other bit was there were 76 completely novel analyses that required the Department of Health and NHS England to publish 40 new data sets on the day that the report was published that had not been put into the public domain before. So it was also a kind of radical act of transparency in that particular moment.
Was there anything you couldn't get data for that frustrated you? That either because it's just not measured, or it just was too messy in order to put it. I mean, like what?
There's a very clear example of where there's a real data gap. So if the big strategy is shift care from hospitals to community settings, I think the most shocking data gap is that we don't currently measure the number of people working in community settings. So we've got some hypotheses. We actually discussed some of those data limitations in the report. So, for example, where a hospital runs the community services as well, so you all know St Thomas's over there. St Thomas's also runs the community services in that part of Lambeth, but you can't differentiate in the data sets between a nurse who's working in the community setting from a nurse who's working in the main hospital building over there. And so that limitation is really critical if the stated strategy is to shift care from hospital to the community and you don't know what the division is in terms of the workforce. That's a very big data limitation. But for the most part, I don't think we had any real problems in terms of getting what we had asked for. It may have taken a bit of trying to get there, and obviously there's a process of sort of iteration to refine and improve the data. But I think the degree of cooperation was remarkable.
Thank you.
I mean, this could be tagged very easily to say it's a hospital employed but community worker.
It's just not done.
It's just not been done. It's a very simple solution.
Very helpful, thank you very much. And so on the basis of this data, you do start to reach some conclusions. I mean, one of them, and you mentioned it in your opening remarks as well, was about the 2012 Act, and in the introduction you call it a calamity, it proved disastrous. Does the data itself prove the causality of that, or were there other factors that you think could have contributed to that? I mean, you do pinpoint the specific moment in time.
I mean, there are a number of things happened from 2010. Actually, in fact, I start with the austerity measures. And we all know, we all lived through this. 2018 global economic downturn was a shock to many, not just the United Kingdom. And so the austerity of 2010, obviously, 2008. 8 was the downturn. The
right.
budget started.
Budget
the austerity
was 2010.
budget was 2010.
Yes, that's right, the 2010 government.
Yeah, absolutely.
Yes.
2010 was the focus was how are we going to deliver this with this tight budget. Mm-hmm. And, there was a lot of anxiety by management, less to the clinicians. It hadn't really filtered down to us. And I think the 2012 Act, if I could say a few words about that, that was one of the biggest reconfiguration. Probably you remember David Nicholson, the CEO of the NHS, described it as so big you can see it from the moon.
From space. Yeah.
Or the space, or whatever. So I think the disruption of that had two consequences. One was you really disrupted and moved the management who were spending weeks of their time really trying to reapply for their jobs. So I think in many ways the hands of the till managing austerity at the same time at the major disruption, I think was the combination of the two probably were amplified the whole deficits that we went into immediately after. So they're the two major trends at the beginning.
So that's an assertion you've made from looking at the data, but it's not necessarily causal, but it's a strong correlation. Would that be fair to say?
I think you can, if you have the report in front of you, page 119, you can see we try to not just assert things, but to have some analytical basis for what was said. And so what's really striking, if you look at page 119, is that in that period of those reforms, there was an attempt to create 320 completely novel organisations. Yep. If you look at any of the other time periods, either before or since, there was no period of such substantial disruption. And so just from kind of trying to demonstrate analytically that this wasn't just an assertion that this was disruptive, you can see very clearly that from an institutional perspective, there hadn't been another period in which such a large number of institutions were attempted to be created. And then if you turn the page, you can also see on page 121 the very noticeable significant spike in the turnover of management. And that's how you get some explanation of the argument that those reforms led to a permanent loss in managerial capacity and capability. But those, rather than being assertions, you can see it in the data.
Yeah,
so much.
Just to add to that, as I said, most people were reapplying for their jobs at that time. So it was a huge turbulence. And people, the controls at a time of austerity, I think, was another factor here.
Very helpful, thank you. My last question before I pass on. So we've now got these three broad themes, and as you said, you recommended sort of 7. To what extent do you feel that the three themes capture the direction that you were trying to push in this report? And one that seems to be missing is no sign of reconsider how the NHS can help deliver prosperity. That's not mentioned specifically within the three themes. If any of your themes aren't covered by the 10-year plan, what would the consequences in your view be of that?
Sorry, Tom, could you want to...
Well, I think the prosperity argument is an outcome of having a better performing health system. So it's not arguing that intrinsically in itself, it's saying that if you can get the NHS to perform at a better level, so people aren't on waiting lists, for example, and are able to get back to work. I think the figure is something like 800,000 people who are, the majority of the people on the waiting list at the moment are on the waiting list and they're of working age. And there's something like an 800,000 increase in long-term sickness that is principally driven by two things, by mental health conditions and by MSK conditions. And that we know, for example, that in both of those things, there have been a big increase in the waiting times.
Yep. But, you sort of haven't quite answered my question, I don't think. So you've got the three themes in the 10-year plan. You've got your 7. Some of them have been included, some haven't. You've told me how, you've come to that conclusion and what you're driving at. But you also, in the IPPR report and in the Guardian article, you said, well, if this is the problem, this is in part the cure. And you point again in that report to this point. I'm trying to invite, what would happen, what were you trying to say beyond this is a problem? You're offering it as a solution, in a sense, to drive something. Lord Darzi, if you wouldn't mind answering on this point.
I mean, the IPPR report clearly showed that poor health and weak economic performance are deeply connected. That's what we're trying to get at. And the COVID pandemic obviously worsened both. And that's really the big punchline in relation to all of that. It wasn't just the three themes, but at the same time is the poor health of the nation, and I think that became more and more apparent, as we say in the report, entering COVID.
As you said in your opening remarks, that was the thing that shocked you the most.
Yes.
Yeah, thank you.
Yeah.
Andrew George.
Thank you very much. And actually, as someone who was a member of the Health Select Committee during the period of the 2012 reforms and who sat on the government benches and opposed those reforms all the way through, you picked at the scabs of my war wounds in that. But moving on to this excellent report, I have to say, and I wanted to cover a couple of themes on primary care and acute side of care and the accessibility to those. In the government's response, they responded with three very creditable themes, which are not going to be controversial, I wouldn't have thought, and certainly no one's arguing for the corollary. In other words, from prevention to sickness, nor to ditch technological advances. But in the area of from hospital care to community, I just wanted to really pursue the extent to which you found the capacity within the service to actually make that change and the resistance to that. So although you're analysing the data as we found out, and we're looking at the problems, you did also advise in terms of identifying major themes, and one was to lock in the shift from of care closer to home and for a neighbourhood NHS. So although you're not recommending policy, you're clearly pushing in that direction. Given the capacity within primary care at present, and it's reduced over time, according to the RCN, a 45% reduction in district nurses in the last 10 years. To what extent do you think that this mismatch between demand and supply will ever be met within that sector?
Thank you. It's a great question. Let me start and say, actual fact, we've been talking about this since 2006. It wasn't the last government, it was the government before. Yeah. Patricia Hewitt came up with care closer to home. Yeah. And obviously I championed this when I was in office at the time in Gordon Brown's government. The problem with this is we've talked about it, plenty of evidence to support it. It's probably the highest quality of care you can provide nearer to home, but we've never done it. At the end of the day, reform needs the resources that follow it. And the sad fact is that never happened, whether that was 2006, whether that was high quality care for all, which also we made significant recommendations of shifting the care to the community. But to do that, you need to invest in the community. And you probably will all know some of the scars on my back, on the back of the polyclinics. Polyclinics was just a name. What was trying to describe is if we are to shift care to the community, we actually need all the tools that exist, a significant amount of technological innovation that actually currently exists in hospitals. Diagnostics. Why are we sending patients to hospitals to get their bloods done? How do we shift diagnostics into the community setting? Endoscopy. Why don't we shift endoscopy? Imaging. Why don't we do that? Then you will come to the challenge, well, we can't do that. We can't put a lab in every GP practice or this and that. What I was thinking through is that if you are serving a population of, I think at the time the economics, Tom may remember this, if you're serving a population of 25,000, you can actually invest in diagnostic tools. Once you have diagnostics, you're actually then empowering many of our general practitioner colleagues who, by the way, have gone through the same medical school as I have, working in a hospital, they're working in the community. They have the same skills as I have. I've obviously specialized to do something else. And give the tools to many are, one of our unique features about our healthcare system is primary care. It's the envy of people in the world. Why don't we give these tools to our primary care colleagues, and through which we can shift many of that care into the community setting? Because if you have the diagnostics, you know what you're dealing with, and then you can stratify patients and their treatment and their management programs accordingly, manage chronic disease better. We've never achieved that. That never actually happened. It didn't happen in 2000. And so that's, and I think we, by the way, if you look at it now in this report, the sad fact is that the reverse has happened. All the resources, actually more resources have gone to the acute setting, and we've deprived the community and primary care, community beyond primary care, deprived them of the resources to do what they're supposed to be doing.
Yeah, and in terms of the delayed discharge, which a lot of people are focusing on, and there's a rather kind of two-dimensional kind of view about that it's the inadequacy or lack of resource in social care that is causing that resistance. However, in Cornwall, I've been asking similar questions, and they have come up with data sets which indicate that only 25% of cases of delayed discharge are caused entirely by social care packages, that in fact actually primary care and acute care at home and all of the other elements of package which are required to safely discharge patients are actually down to NHS problems. I mean, is that something which you identified as well?
Absolutely.
And is those kind of proportions?
I don't know the exact figures. We have them somewhere, but
So the total number across the country is about 13% of NHS beds are currently occupied by people with no criteria to reside. But you can, as you say, decompose that. Some of those are purely by social care. Some are also waiting for care in other settings. Some are waiting for a package of community services. I think the data definitely exists for that breakdown.
We'll come back to this point.
It's actually in the report.
It's just no, exactly. I couldn't find it in the report, and I just wondered whether that
exists.
That was very. And then in terms of geographic variation, I mean, you do highlight the distinction between, I think, Devon and northwest London. I think it is, where there's very significant difference in terms of caseload as far as GPs are concerned. I mean, would you not agree, though, that there are demographic variations? Just walking around London, you get knocked over by skate. So it's a much younger population. In North Devon, it must be an older population. Therefore, those kind of variations are bound to happen, aren't they? I mean, is that a good or bad thing? Are you suggesting that it's that needs to be righted, or it's simply an observation?
I'm not trying to rearrange the demographics of the different parts of the country. Is how do you plan and commission the health resources that are available to you based on the population you serve, and obviously Devon's needs will be slightly different than Northwest London's needs.
Right. Yeah, and then
Thank you. We've got to move on to
very last. Just what last question on emergency care. In response to your report, I noticed that Dr. Adrian Boyle, the president of the Royal College of Emergency Medicine, is saying that there is a ward of patients waiting to be admitted within the in every tertiary centre. So the pushback against that shift of resource from hospital to community is already begun. So from emergency medicine point of view, they're saying because of the ambulances queuing outside, they're unable to admit patients. They're saying there is more resource needed at the within tertiary centres to be able to admit patients. I mean, is he not right that in fact actually that resource also needs to be increased as well?
Well, there's an upstream and there's a downstream.
Yes.
You can admit more patients if you don't discharge the patients that could be discharged. And if you don't fix the problem in primary and community settings, you're always going to have patients lying in beds and others waiting in the A&E department to be admitted into those beds. We're not going to be doubling the number of beds that we have in a hospital setting. Otherwise we'll end up hospitals providing community services. That's not the model, and that's not the right thing to do. We've always struggled with this historically, but it is significantly worse than it could ever be. I mean, let's give you one example. The consequences of that. I'm a surgeon. Many of my colleagues, we're sitting in operating theatres, scrubbed, ready at 8 o'clock in the morning, waiting till about midday for a patient to come down to the operating theatre. Operating theatre is like an airplane. It's expensive, it has about 6 or 7 people working in it, and it's vacant. It's vacant because we're all waiting for a bed to become available to admit a patient for an elective procedure who've been fasting for 24 hours the night before to come in. Their relatives have got them into the car and got them to the hospital. They're waiting in a cold waiting room to be dressed up, for a bed to be available, to get into the bed, to get the diagnostics, and then to be brought up to theatre. So that has to change.
Thank you.
Thank you.
Jane Croft.
Thank you. Just like to move on to touch on a sort of slightly different area, but again, it's looking at where you kind of see the sweet spot almost between more investment in prevention work and dealing with what is quite a significant backlog of acute treatment. And that's in the area of mental health care access. And you highlight that this is particularly acute for children and young people experiencing a mental health crisis in particular. Where do you see sort of the switch from occurring? And do you think it's right that there is do you think the priority should be to address the backlog of a significant increase in children and young people experiencing a mental health crisis, or should it be kind of looking more to preventing that occurring in the first place? And is there sort of a very sweet spot of harmony to be gained in between the two?
I think you have to do both. I think you have to reduce the burden and you have to address the burden currently in front of you. What we have is a huge burden when it comes to mental health services, and we're not really addressing them. We need to get on and do it. 100,000 adolescents with ADHD are waiting for a year for an outpatient appointment. That is not good. And that needs an urgent and immediate action. We're talking about the future of this country. We're talking about young people. The other one was, probably not mental health related, was 2-year-olds. 100,000 2-year-olds are waiting in A&E for more than 6 hours. So there is an immediate, acute problem that has to be addressed. And at the end of the day, it's the management physicians, nurses, allied healthcare professionals all working together to address that acute problem with the support that comes from central, but also from locally. The second question is, how do we prevent these things? You're absolutely correct. At the end of the day, as we say, prevention is better than cure. We have a probably one of the most distinguished public health physicians as our chief medical officer, and working with the profession, the prevention has to be the core. One of the unique advantages of the National Health Service single payer system is we can do this. We've done it before in the Victorian era, and we led the world. We could redo it again based on the new technology platforms that are available to us, digital, all aspects of innovations in technology that could address these major issues, like online CBT, for example. Who would have thought 15 years ago that we will have cognitive behavioral therapy online? And there are many, many innovations in the field that we need to utilize and expedite.
And on that, so specifically on children and young people, you do sort of touch on that there is perhaps more serious implications for them not being seen in a timely manner. I think you mentioned childhood is precious, and it being eaten away by being on a waiting list is sort of unacceptable. I just wondered if you would like to expand further, and if you see that there is perhaps a strong argument for putting more investment into services for children and young people, not necessarily just in the field of mental health, as opposed to sort of adult services, if now is the time to really look at moving that more towards paediatric, particularly mental health services?
I'm not the expert in shifting budgets here. I'm not running the National Health Service, but I could only make one remark. Our children are our future of this country. Their educational years are the most important years in what happens to them. So if we don't invest in them, there's something wrong with us with the societal values per se. And that's why, if there was one area that I was most shocked by, was the mental and physical health of our children and our future. So I don't think we should, I wouldn't, it's a no-brainer, this. This is the future of this country.
Thank you. And just to really briefly touch on just another sort of thing that emerged from the report, one of the things that seems to be a recurring theme is the lack of responsiveness to the patient voice in terms of quality of care. And that's where there have been fairly serious issues in terms of maternity services, learning disability care for adults, and sort of, again, mental health care. Do you see that as being having more of a specialised patient voice coordinator on an individual level, or more in terms of sort of design of services and how that's implemented?
To be honest, both. Being a good clinician, half of it is about listening. Otherwise, you're in the wrong profession. And it's you can only improve things by capturing from the users of the service or what they think should change. And I think we've made that, why do we do huge public consultations? Why do we do a lot of co-production of pathways of care as we did in High Quality Care for All? We involved thousands and thousands of patients. The one that I was most proud of when I did the London Framework for Action, we had 100 members of the public and patients with me for 1 year, looking at every pathway of care. We seek their views, what should happen, including children and adolescents. What are the transformational opportunities here? So you have to co-produce, you have to empower both the user of the service, but also the public, who are paying for this, by the way, in redesigning health. That's the essence of high quality provision.
Just what are the blocks to that happening on a wider basis?
Well, I think that as performance deteriorates, right, the pressure on staff tends to go up and the degree to which they're responsive tends to go down. So there is a sort of virtuous circle where, as performance improves, you get better and more responsive care for patients. So I think these are related issues. So the issues around responsiveness, if staff are feeling rushed off their feet, if they don't have the right equipment, if they're spending their time trying to chase beds, and all those different issues that we know exist, they're much less likely to be immediately responsive to patient needs. And if you're a patient, the first thing you want is to be able to get through the door. Right? That's the first level of responsiveness. At the moment, the elective waiting list is 7.6 million people. So if you're right at the back of the queue, the degree to which a service is responsive, well, that's the first question. Can you get access? Once you're through the door, there's a question about the quality of the interaction, the quality in care. We know there have been issues in maternity, but also in a number of other services. But those things tend to be related. If you can solve the access problems, you can solve the productivity problems, that means that you can start to raise the quality of care and be much more responsive to patients.
And, happy patients, happy doctors, happy nurses, that's the model. And I agree with Tom. There's a huge amount of strain on many clinical colleagues and managerial colleagues. It's not easy to work in the National Health Service at the moment, and that we should all recognise that, and we have to address that, because if you're not going to address that, sadly, that moves more patient-facing, which is tragic, because the last thing patients need, they come in there for support and for care. Having someone who's really overstretched, hadn't slept overnight, because I'm on call and the morning everything is delayed, you could see how it could end up into a bad place.
Thank you. Thoughts I'm sure are echoed by everyone on this committee. Joe Robertson.
Lord Darzi, thank you very much. Your report, the remit for your report didn't deal with social care specifically, but you understandably and rightfully refer to it to the extent it impacts on the NHS. So if I could ask you some questions on social care. To what extent is it fundamentally sustainable if we're to achieve integrated health and care, to have a social care system, if it can even be called a system, that's funded and dealt with so differently to the NHS, which of course is universal and free at the point of use, social care means tested, a mixture of private funding and funding through local authorities. Is that a fundamental problem for the future, particularly given our growing older population?
Thank you. It is a serious problem. It's been a serious problem. It is a serious problem. And if we don't fix it, it's going to get significantly worse. So, and by the way, we know this. Successive governments have really failed to address this issue. And we remember, I was actually was appointed at the time in Gordon Brown's era, where he introduced the proposal of free personal care paid for by compulsory levy, if I'm correct, on the person's state. That was called the death tax. Do you remember that? And the whole thing fell apart and sadly did not get anywhere. There was the Dilnot Commission, which made recommendations following that, which was he certainly recommended more generous, mean tested, and a life cap on the cost of care. And then David Cameron came in, as you remember at the time. There was a lot of talk about that, but didn't happen. Theresa May came in with her proposal for this, and I'm not sure what that was called, dementia tax. Am I correct? Yeah. Mm-hmm. And then the last one was obviously Boris Johnson, who I remember actually even having a conversation about that at the time, and it was based about a national insurance system. It's just, if we don't address this issue, we're going to keep the strain on the NHS. The problem with that, we're not getting value for money for every pound we're spending in the NHS if we haven't fixed social care. So that's really what I have to say about this. The impact is clear, you know that, and I think it's something critical needs to be addressed.
Thank you. Your report finds serious long-term underfunding in social care, quite apart from the structural issues, and remarks on the knock-on effects in the NHS. The current government has made its first decision on funding through the budget and allocated broadly 26 billion for the NHS and 0.6 billion or 600 million for social care. So in percentage terms, that's 98% for NHS, 2% for social care. In your view, is that an appropriate apportionment of the funds available as between NHS and social care, 98% versus 2%?
I think social care needs, beside the input, which is the money, it needs a complete reform and revamp. And I don't think it's fair for me to answer whether 600 million is adequate to really sort social care out. I think it needs a much deeper surgical procedure.
Yeah. No, I appreciate it's not your decision, not my decision, where the money goes. But given that your report looks into decisions made by previous governments, yes. I'm inviting you to make a comment on the current government's decision around funding made in October. I appreciate the system may not be perfect.
Yeah. My advice would be to all political parties to come together to think through what's the best solution for this problem, which sort of always gets batted off to the side, because if we don't fix this, we're not serving our elders, by the way. Let's start with the principles of this, rather than thinking about the NHS. Obviously, it has significant consequences of the NHS, but we need to address this big gap that exists in caring outside hospital and social care.
Just looking at continuing health care, which isn't directly dealt with in your report, but I accept, again, social care falls outside, but continuing health care being effectively social care commissioned by the NHS. I think it's uncontroversial to say that fewer people are receiving continuing health care, and there is in many cases a breakdown between NHS and providers. I wondered if you had any comments to add about the way continuing healthcare is provided and the challenges that it faces.
Yeah, I mean, Tom may come up with the figures. The only thing I'll say, if we don't have a reasonable quality continuity care in the community, the sad fact is a lot of these patients will be back in the system. And we have to somehow or the other find a way to break that cycle, because that's actually ends up costing twice. If I'm correct, I don't have the figures here. And that is one of the principles of keeping people healthy and preventing relapses out in the community.
Yeah.
Do you want to say, Don?
Well, I mean, so on social care, I think it's important to remember it's not just older adults. It's also, I think even the majority of the spend is on working age adults with learning or other disabilities. And so a huge amount of it is just taking care of the most vulnerable in society as well as older people. And in terms of what needs to happen, in a way, there have been plenty of different proposals and plenty of different commissions. There's just a question of can you make a decision and make a choice to execute it. But I don't think there's a way for you to answer immediately whether the funding distribution is correct or incorrect. On continuing healthcare, I think it is just worth, we didn't cover it within the report, but just in terms of the definition, it's not just social care paid for by the NHS. It is care for people who have a continuing medical need, and that's why it falls within the scope of NHS services to cover it. It's not just where the NHS has made a particular decision to provide social care for one person versus for another. There are very clear criteria around it being principally a question of medical needs that are driving the cost rather than being a question of social care needs.
Yeah. Thank you.
Thank you. I was really interested in your point, Lord Darzi, about the people coming back into the system, not for now, but you may be aware the committee has launched an inquiry into social care, the cost of inaction. And if you have further thoughts on this, may I please invite you to submit evidence that is now open to that inquiry. We will be returning to this issue in depth in the new year. Thank you very much. Ben Coleman.
Yes, thank you. Lord Darzi, it's good to see you here today, and I very well remember your distinguished time as a minister in the last government on health, which informs all of what you're saying as well. And I'm speaking I would like to talk a little bit about local authorities and the relationship between local authorities and the National Health Service specifically. And I'm speaking as a former Cabinet Member for Health and Adult Social Care and former member of an Integrated Care Board. And the council where I was the Cabinet Member is the only place in the whole of England which provides care at home for free. So just worth mentioning that. The challenge, you talk about the system needing a complete reform and revamp, but isn't part of the problem the failure of the NHS and local authorities to understand each other as well as they could? And particularly my experience is that local authorities understand the NHS to a degree, the NHS really doesn't understand local authorities. Partly that's a result of the NHS being top-down and local authorities being bottom-up. That's my perception. Do you recognise this situation? And if so, what impact do you think it has on how social care is perceived and addressed by the medical establishment? And is it seen as an essential part of the system by the NHS and the medical establishment as a whole, or is it seen as an inferior part of the system?
I mean, these are two separate questions. I think our system will never work if we don't have, social care and the NHS on two sides of the same coin. They have to be working hand in glove together. And I know that at a patient level, who someone in their late 70s I've operated on, we're ready to discharge the patient, and that patient is remaining in the bed for another 4 or 5 extra days, despite the huge amount of innovations and doing it robotically or keyhole. You can't discharge the patient without adequate support back in the community. And that's something, as a clinician, it's very difficult for us to address, but I think the two need to come together to find ways. And it depends, by the way, which local authority, which NHS hospital. There are some amazing partnerships. It works extremely well. And in some areas, it doesn't work well. That needs to be addressed. That needs to be aligned. And it's interesting because you ask the social care, they would think the NHS is not their greatest partner. If you go to NHS, they talk about social care is not ready to receive them. So somewhere in between, and I think with your political hats, you can try and find ways of addressing that issue. But at the end of the day, the loser here are the patients, and obviously the other patient that might be coming in to have the procedure. So yes, there's plenty of scope doing that. And by the way, we've done this. If you remember, in the old infectious HIV days, local authorities play a significant role in really driving community delivery and setting up even clinics in the community. So there is a huge scope of innovation, but I haven't covered this in my report, as you may know.
You think that it would be helpful if the people in the NHS took more trouble to understand how local authorities work? Because I think there's a danger of dictating from on high, and that's not really how it operates effectively on the ground.
I agree with that. I support that.
Thank you. Just talking a little bit more about local authority resourcing, and you talk about housing and the importance of addressing housing and damp and mould, and local authorities obviously have their own social housing, and they will be getting more powers soon as a regulator of standards in the private sector. Do you think that the NHS should argue for more resourcing for local authorities when it comes to housing, as it should for public health? We talk about public health and social care, but should the NHS actually see it as part of its job, battling for more local authority resource?
To itself, or to support local authorities in their case?
From the government to local authorities, yes, so that you have fewer people living in damp and mould and in other situations.
It's a very logical answer is yes.
It's not possible to get the NHS outcomes we want, is it, without funding these other things better?
I couldn't agree more, but also, smoking cessation interventions by local authorities, many other interventions that local authorities could make that will have a positive impact on the NHS.
Yeah. Well, finally, and forgive me, this is slightly off-beam, but again, a particular aspect of the relationship with local authorities and generally that concerns me is what's happened since COVID, what happened in COVID and since COVID. And I noticed that you said in your report that the impact of COVID on the NHS seems to have been far more severe than elsewhere, and that we went into the pandemic much less well prepared than other people. But my interest is in what have we learned since? And I have the impression, and again, you may correct me on this, that there's been very little, as a health and care system, very little attempt to learn from COVID. In particular, the way that the NHS and local authorities worked differently during COVID, including whether local authorities, on occasion, intervened forcefully to stop the NHS from doing things which might have endangered lives. That hasn't been explored. Yeah. And do you know any attempt has been made of whether NHS and local authorities, how they work differently and better, has actually been made, and do you think it should be made?
This is well above my pay grade. I'm a surgeon who works in a hospital, sir. But what you're saying makes a lot of logic. There's no question that the two should be working hand in glove in terms of addressing the demand side of health needs, but also reforming the supply side. And I very much hope that that will be part of, by the way, the 10-year plan that the Secretary of State has launched. And I'm sure you can feed evidence into that.
Thank you, that is helpful.
On the COVID, by the way, on the COVID we just need to wait for the inquiry. There are many lessons to be learned from COVID, and we're all anxiously waiting to see what the inquiry will say.
Is the inquiry, then, which you know more about than I do, is the inquiry looking particularly, and this does concern me because I was the cabinet member and other people here were cabinet members during COVID and trying to protect our populations, and it was extremely difficult when the NHS, for example, pushed patients at the beginning of the COVID pandemic out of care homes without testing them. We lost 50 patients people living in our care homes at that time, until we were the only council in the country to close our care homes because the NHS wouldn't stop doing that. There's a lot that can be learnt of how local authorities acted and their role in preventing more deaths during COVID. Do you think, from what you know of the inquiry that's taking place, that that's going to be looking at that, or should separate work be done on that?
I am not involved in the inquiry, and thank goodness I'm not being asked as a witness to the inquiry. It's not fair to me.
He knows more about the inquiry than I do.
I am as anxious as you are to read the recommendations of the inquiry.
Thank you. Thank you very much. Can we go to Deirdre Coskin?
Thank you very much, Lord Darzi and Tom, for coming today, and thank you for your very sobering but sensible, I think, report. I want to ask you just a few questions around inequalities and prevention today. So the report outlines the deterioration of access to health services, but how that has been felt differently by different communities. So there's been an inequality in how those services have been experienced. And I represent Ealing Southall, which is in North West London. And we know that North West London has a ratio of 1 GP for every 2,268 patients, which I think is the worst in the country. And it's something like 550 extra patients for every GP compared to the national average. And Ealing Southall is an area where preventable deaths are significantly higher than the UK average, and where people of Asian descent in particular die much earlier than they should because of diseases like diabetes. And that's just one example, but how can, and I think the GP funding issue is a concern when it's based on the number of older people in an area. When in an area like Ealing Southall or North West London, people die earlier, so it doesn't make sense to base it on that. But that's just one example. How can we take the steps outlined in your report in a way that doesn't just replicate the inequalities that are currently in the system in a new NHS as part of the 10-year plan?
Do you want to take this?
Yeah, so I think it's a great question. It's clearly a serious issue. What I would say specifically on North West London is that although the number of GPs is relatively lower, the actual spend on primary care is actually significantly higher than the national average. And one of the consequences of that is actually the productivity of the hospitals is better in North West London than it is in any other part of the country. And that you can see that virtuous circle of having more investment in primary care. So there's a specific problem around, are there enough GPs? But actually the investment in primary and community care is I think it's 40% above the national average in North West London itself. When it comes to the implementation of the plan, there's a question about, in all these things, how do you change services and how do you incentivise the right thing? So, for example, we know that across the country there are a number of places that have too few doctors, called under-doctored areas, in the sense of they have, compared to the needs of the population, a smaller proportion of doctors. One of the reasons that sits behind that was the decision to change the allocation formula to shift the emphasis on deprivation towards a greater emphasis on ageing, or on age structure. And so I think the deprivation index went down from something like 15% to I think it's now something like 10.7%. And so you can see, it sounds like a quite technical question, but it has real-world consequences for inequalities. So as the plan gets developed and they think about things like the financial flows, there's also a choice in terms of how you design those mechanisms. Do you design them where they are blind to these issues, or do you design them specifically to try and shift resources so that they more accurately reflect the population need? And I think that will be a very important theme for the 10-year plan, to make sure that the resource profile matches the actual need of the population in each different place. Because, as you say, in more deprived communities, they have greater healthcare needs.
Right. The report also outlines that one of the shifts is moving from sickness to prevention, I think is the model, looking at the cause rather than the symptom. But we have been talking about prevention now for decades. Equally, as you say, we've talked about moving to the community for decades, but it's a similar issue with prevention, and one of the barriers has been funding, because of course whilst you need to fund preventative measures, sickness continues. There's not an immediate impact on sickness, so the NHS still has to pay for those acute services as people fall ill. Do you have any insight in how the NHS can, in a sense, fund both of those things at the same time for a period of time, whilst we move to a model where the need for the sickness services reduces and we reach an equilibrium?
So there's actually two different types of prevention. There's primary prevention, which is improving modifiable risk factors. So that's making sure people don't get sick in the first place. But there's also secondary prevention, which is where, so if you take somebody who's got diabetes, there are, I think, 8 care processes that we know that everybody who's got diabetes should have every year. So those include things like foot checks, so podiatry would be a good example, but also screening for any macular degeneration, which is associated also with diabetes. So there are these 8 care processes. At the moment, in terms of secondary prevention, across the country as a whole, there's something like 60% of people who have diabetes get all 8 care processes. Now, in fact, the immediate opportunity that would, in fact, free up resource is to ensure that those people who have diabetes, that 100% of those people get the 8 care processes. There's also the NHS Diabetes Prevention Programme, which I think has shown an impact of a 35% reduction in the number of people who go on to get diabetes. So the long-term answer is we need to do both of those things simultaneously, but secondary prevention in the short term, you see a much more immediate gain, partly because if you improve the quality of care that someone has who has long-term conditions, they're less likely to have an acute exacerbation, and therefore they're less likely to show up at hospitals. There was a question earlier about, well, the patients keep coming to hospitals, so shouldn't we put the resource there? The answer, in part, is if you were to do those care processes for all the people who have long-term conditions now, they would be much less likely to show up at an emergency department. And so on your question on prevention, I think the answer is you need to be able to do both of those things. On primary prevention, I think it's also worth being aware that since 2015, there's been a 25% real terms cut to the public health grant. So in just very practical terms, we are just investing significantly less on public health than have been over the past decade. And that's a choice, of course, for any government about whether it wishes to invest in public health, which tends to have a long-term payoff, or does it put its resources into the immediate issues of patients in emergency departments.
No, oh, sorry, Lord Darzi.
Just, this is quite close to my heart as well. I mean, I always say all surgical careers end up with failure when you realise you should have done public health. Tom very eloquently answered this. I think we have an unbelievable chief medical officer, Sir Chris Whitty. He's just phenomenal, really, in terms of public health and what he's trying to get through. I think we had some structural changes during COVID. I mean, we're the only country that dissolved Public Health England in the midst of COVID pandemic, if you remember. Mm-hmm. And so the question is, how do you then, as Tom said, the Health Security Agency deals with the threats of infectious disease. So who's going to deal with the public health delivery side? That is, as Tom said, is in the NHS. But what's important is to get that balance right, because it's actually, you could say they're aligned, because if you don't invest in public health, you're going to increase the burden of disease and the utility of your hospital or your health infrastructure. So something needs to be done about that. The bit also I want to talk about here is the primary prevention, which there's some amazing scientific advances happening in primary prevention in terms of detecting pre-disease states before they actually have symptoms, and how we can, being a single payer system, how could we really exploit these opportunities? I think there is huge. Public health is a real amazing opportunity for us to re-engage, to reinvent it, believe in it, and we have the right leadership for it. So I hope the government does put as much resources into public health as they promised they would do.
And I think Becky's going to follow up on a couple more questions around public health. But just finally from me, I think it's the IPPR report that refers to the 900,000 people who are unnecessarily off work due to long-term sickness. And you focus on how we can bring those people back into work and where they want to work. Is there anything you can say, however, about those who are currently in work but have potentially a long-term condition and aren't getting the help that they need from their employer in terms of reasonable adjustments? I know there has been research done by my previous employer, Unison, that people often wait a year or more for reasonable adjustment requests to be put in place. So how can a properly preventative healthcare system work with employers to avoid these people falling out of work and avoiding that waste of talent and the loss to our country's prosperity?
Yeah, I mean, Tom will come in. The return on investment in public health is very obvious to everyone. It's a multiplier of at least 15 to what you spend for every pound on treating illness. So that's not new. We all know that. And I think the IPPR report made some suggestions, estimated 5 billion loss in tax revenues due to long-term sicknesses, and the recommendations we made at the time was new levies on unhealthy foods and better health regulation. That was de-incentivizing insecure, difficult working and setting up a 30-year target to increase healthy life expectancy by 10 years. And I think the only way we could do this, and again, having someone like Sir Chris Whitty, is a cross-government, mission-driven opportunity here really is crucial to drive this. And I hope that happens as part of the 10-year plan.
Could either of you say anything about the reasonable adjustment point that people are currently in work?
Okay, sorry.
Well, look, I think it's a very good point. We know that work is good for people's health overall. It's good for their health and well-being. And so keeping people in work successfully is likely to be good for them, but also good for society and good for the NHS ultimately. So I think the point you raised about the issues around reasonable adjustment are important. And I suppose if you were to think about the NHS of the future, what would you want it to be able to do? So if you believed in a more preventative NHS, you might believe that one of the things that it could offer, I'm not sure that it does so much today, would be assisting employers to make those reasonable adjustments, right? Or providing some of the evidence and guidelines or options for those reasonable adjustments. I think there's another thing, though, which is also just connects back to some of the basic questions of responsiveness. So all of us, I think, have probably experienced for ourselves the problems in accessing care. And that expresses itself in a couple of different ways. One of those ways can be just its long waiting times, but the other can be in the slightly chaotic way in which things tend to get organised. So I think between having an appointment on a Monday, I first received notification of it on a Friday. I got a text message. Then I got a further 4 text messages that changed the time 3 times over the weekend. Then the final one said it would be a different time. Then they called it the original time on the Monday as it happened. And then 3 weeks later, I got a letter through the post saying, you'll be having an appointment in the past. Naturally, for anyone, that's quite hard to plan around a job. So there is some of it, which is, I do think part of it, absolutely, could the NHS do more in terms of assisting employers on reasonable adjustments? But there is something about getting our own house in order first, getting some of the basics right so that waiting times are reduced and that it's easier to book an appointment and that those appointments are honoured, because we record the did not attend rate. We don't record the how many times did we cancel and move it around rate. And I think a lot of that would go a long way to helping people who have long-term conditions to be able to stay in work if the NHS, in its core activities, were able to be more responsive rather than necessarily thinking about these sort of new frontiers, which I think you make a very good point. There could be a contribution for the NHS there.
Thank you.
Right, thanks.
Cooper.
Thanks so much, and thank you for giving up your time to come along today. So, Lord Darzi, as a public health consultant, I don't hold it against you that you chose to become a surgeon, but I am glad that you've seen the light. Welcome to the good side. Thank you. So, as Deirdre says, I just wanted to pick up around the prevention agenda and some of the more strategic aspects of it. So, in your report, you refer to the breakup of Public Health England during the pandemic, as you've already stated. And the wording of your report suggests that you don't think that this was potentially the most beneficial action for public health in the UK. So could I ask your thoughts on the subsequent setup of public health departments in the UK? And for clarity, obviously you've referred to the Health Security Agency already. We have the public health teams in local government, and we have OHID sitting in the Department of Health and Social Care. And specifically, and I hear you when you talk about Professor Chris Whitty, and he's absolutely excellent, but the Chief Medical Officer does have a specific remit. So that remit aside, do you think we're now well served with strategic public health leadership? And does your report give any insight as to how we might improve going forward?
Thank you. My report was diagnostic. You appreciate that. It wasn't any sets of recommendations. I'm sure the 10-year plan will have its own recommendations. I think the point I was making is dissolving a structure in the midst of a pandemic. I was being a bit cynical, if I could just say that. I don't understand why the reasons at the time, but I'm sure there were good reasons for it. I think Health Security Agency is doing its job very well. I think what I was trying to say is we have the Department of Health and Social Care and we have the NHS. I think, what we need to think through, what are the powerful levers that we can give at a time where we have a Chief Medical Officer with public health global expertise. How do we those levers to really drive the public health agenda within the National Health Service, considering all the strains and all the challenges we've just been discussing? Because I think secondary prevention is critical, but that is never going to happen if we're constantly chasing the big other challenges. I mean, the long list of challenges facing the National Health Service at the moment. We need to find a way of prioritising the secondary prevention and the public health agenda. That's the only. It's more of. I'd love to see more of that, and I'm sure that will happen in the 10-year plan. I have no doubt that we will see much more reinforcement of the contribution of public health.
So just to follow up, just to be clear, do you see strategic public health leadership currently sitting solely with the CMO? I mean, I know there are leaders, obviously, in OHID and the Health Security Agency and the Association of Directors of Public Health. Or do you see the need, perhaps, for, to coin a phrase, a truth to power leadership that might need to sort of complement the CMO's role?
I have no opinion about this. I really don't. The only thing I could say, you have an amazing leadership in the CMO to drive this, and I will use him rather than create a different organisation.
Thank you, that's really useful. So just moving on a bit and looking at the general funding setup, and I know that, Tom, you've already talked around this when you've been talking about the inequalities and health resource allocation. Again, sort of reading through your report, I wondered if you wanted to comment on whether you think there's a better way to distribute funding through our health system, and specifically perhaps picking up on a couple of Ben's points around local government. Do you have any thoughts on more fully devolving resources and responsibilities for health services, perhaps to run in parallel to the planned devolution agenda for local government?
Well, I think there's been some experimentation in this area. So there was obviously the effort, Devo-Manc, as it's called, to devolve health and social care budgets to Manchester, and that's been through various different evaluations. I suppose there's a kind of question about, would you want to devolve health budgets to local authorities? I think that's what you're getting at, and there's been a long kind of tradition of people arguing for that. In this report, we look very closely at the distribution between different parts of the health system. So if you take that shift from hospital to community, having said that very loudly in 2006, for the next 18 years, we've gone in the opposite direction. So in 2006, the hospital sector accounted for 47% of spending, and by 2021, which was the last year that the data was available, it accounted for 58% of NHS spending. One of the notable changes that I think has had a very positive impact has been the mental health investment standard. And what that's done is it's protected mental health budgets. So if you look in the report, you'll see that in the first period of the 2010s, there were very, very deep cuts and reductions to mental health expenditure. That was then reversed in 2016 onwards, and you see that it's a kind of U-shaped curve, so that by the time that you get to the end of the period, we've kind of recovered back to where things had started in 2010. And the mental health investment standard basically says that mental health spending will increase at the same rate as the wider NHS budget, plus a very small, I think it's 0.6%, 0.7% each year. I do think one of the recommendations around locking in financial flows in a particular direction, that would seem to me that if we really believe in this idea of shifting from hospital to community, then we ought to be considering expanding the scope of the mental health investment standard so that we create a similar investment standard for community services and for primary care, so we stop this long-term drift of more and more resources into the acute sector, I think that would have a much more significant impact on the overall sort of pattern of services than something that was aimed at somehow changing the way that they're distributed amongst ICSs to involve local authorities. I think Ara's very clear in the report that reorganising the system again would be detrimental to its performance, and so that kind of radical reorganisation to hand it over to local authorities, I think we would see that as a largely harmful activity, but changing the financial flows to actually lock in the shift of resources so that we match our words with our actions could be very powerful, and hopefully the 10-year plan will have a look at that.
Thank you. Next question.
Yeah, thank you. So just to be clear, I think I was thinking about sort of not the old regional health authorities, because we just keep going around in circles, but perhaps the integrated care partnerships, looking at what they're able to do and what perhaps they're not doing now, and whether if we are going to be serious about sort of decentralising health alongside social care to give parity of esteem with those two areas, whether that is something that we should consider.
Also, NHS England has just devolved the specialised commissioning budgets to ICSs. So ICSs are taking on a greater and greater share, and each of them consists, it's quite complicated, of an ICB, an Integrated Care Board, which is an NHS body that is part of an integrated care partnership with local authorities. So that structure already exists. So as the scope and scale of ICSs expands, hopefully that will also be a good basis for closer working with local authorities.
Thank you. Josh Fenton-Glynn.
Thank you. And thank you so much for the report that you produced. It's incredibly detailed and an incredibly good, as you say, diagnostic starting point. Your report details the 2012 reforms and how they took away a whole layer of management, and what we've essentially seen then is that management being rebuilt and kind of restructured through the ICB setting. I wonder if, in your opinions, the management lines are now sufficient for the running of the health service, and if you draw it on a blank page, is that what it would look like now?
I think the management lines, or at least the management structures, have matured since 2012 with a process of iteration, mostly Darwinian, if I could just say. And I think we have what we have at the moment, and I think we haven't really looked. The report wasn't about looking into the future. I don't think there is any suggestions of change again, as Tom just said. I think it's for getting these to execute their roles and responsibilities in better commissioning, managing provision, and whatever else that goes into their portfolio. Yeah.
And I guess, a big part of this report is the failure of left shift. One of the figures that you put in the report was the community nurses. Our numbers are 87% lower than the OECD average, and I know that statistic isn't exact because of how they measure them attached to hospitals. But I think I've used the phrase before in other circumstances that what gets measured gets mended. And I wonder if you would think that to do community and left shift better, we'd be better kind of doing some more measuring in that sense.
Yeah, Tom did the... Yeah, please.
Yeah. Absolutely. So the first thing we have to do is to start counting it properly, because if we don't, how can we know whether we're succeeding or failing? So you're absolutely right. That figure around the 87% versus other countries, we know that's not right, because we know that there are enough trusts that are hospital trusts that also provide community services, like the example of Guy's and St Thomas's across the river there. But having said that, we also know that even if you were to account for all of those, we probably still have significantly lower levels of community provision compared to the OECD average. But the first thing, you're absolutely right, what gets measured gets mended, and if we don't start measuring it, we'll never know whether we're fixing it or not.
And just to follow up on that, if you don't mind, could I ask, in your opinion, what does good look like then? What does a kind of good, devolved social, like health system and a kind of proper left shift look like? Is there an international example? Are there particular boards where it's done well? Or is there anything else that you'd kind of point to?
That's exactly what we're going through on the 10-year plan, to be honest, by quite a big consultation, as you will know.
But you've not seen it elsewhere, is the question.
Yeah.
I mean, you certainly see it in Scandinavian countries, for example, right? You'll see a much higher levels of out-of-hospital provision, but you also see it in a number of other different systems. In France, there's a greater level of out-of-hospital provision. There's also a great level of hospital provision at the same time, but then they spend significantly more on healthcare than we do. But I think there are plenty of examples that you can look at internationally where people have made these kinds of investments, but also here in the UK, you can see the impact of greater investment in out-of-hospital services.
You mentioned North London, for example. Is there anywhere else that we should be training
Whitstable,
our eyes on?
I think, has a very good example in Whitstable. There are some other parts of the country, I'm sure we could come back to you with some suggestions of where's doing it well already. So I think most of the time the NHS, you can usually find that there's some place somewhere where they've kind of cracked it already. The problem is, can you do it with sufficient scale and consistency in other parts of the country?
Thank you.
Thank you. Paulette Hamilton.
Good morning, Lord Darzi, and good morning, Tom. I've read the report with great interest. Lots of it, I believe, I've read before, seen before, and it seems to have brought things together like a bit of a Bible where people can go from start to finish. So I have thoroughly enjoyed the report. I'll start there. My question is about ICB boards and were they fit for purpose. In the report, you actually said that you felt they were fit for purpose, but you highlighted that the functions of ICB boards remain unclear and in some important respects. But you also talked about there was duplication of functions between ICBs and the providers. I've been involved with this since Simon Stevens' days when he was the head of NHS England in 2014 when STPs come in. I don't like, but I can't remember what STP meant, but when it first started and up till now. So I was interested. My question is, how would you, Lord Darzi, want to see services standardised with all that work that's gone on in the past?
Yep.
Thank you.
I mean, I think what you've just described was a process of maturity of the ICBs. And if you look at the early days, yes, there was a lot of duplication. I think that is becoming these organizations. I mean, that's the problem in reorganization. Yeah. You know, you're giving birth to new structures, probably the same people, but without actually knowing what their powers are, what their tools are. And that's where you will see some of the wastage, if you like, as they reach a stage of maturity. I think they are doing better than they would have done, but there would have been overlaps. I mean, the example we've just given you on ICBs appointing, provision of certain community services at the same time the NHS hospitals might be providing the same. So who should be regulating? I don't know who does. Is the commissioning, NHS England should be.
Yeah, so I think the issue is there is some duplication of functions, and the duplication on the provider side and on the commissioning side. So, as an example, some ICBs employ a lot of people in infection prevention and control. Quite why is a bit of a mystery, because the providers also have infection and prevention and control functions, and the boards are accountable for that. So you have a situation where you have sometimes hundreds of nurses employed in ICBs, in infection prevention and control functions, but their only function is checking that the providers are doing their job. Now, given that the providers have boards that are meant to be accountable for that activity, it's unclear to me why you would then need another set of people making sure that the original set of people were doing their job. Why would you not hold the board accountable for fulfilling its function? So that's a kind of tangible example. The stuff on performance management has also been relatively unclear. Is that the responsibility of the ICB? Is that the responsibility of the region? And similarly, there was this whole thing of abolishing the commissioner-provider split, but there are still commissioning functions that need to be done, and more of that is getting clarified. So I do think we have seen, in the past few months, some clear positions that have been communicated by Secretary of State and also by NHS England in terms of who's going to be responsible for what tasks, but where the report says that there are those duplications and a lack of clarity, I think it's getting at those things that are now in the process of being clarified. And as Ara says, when you create a whole set of new institutions, everybody has a different interpretation of how to do the job and what the scope of the job involves. In the trust that I chair, we operate in 5 different ICSs, and you can see from that experience the diversity of approach that's taken in different places. So as an example, one of the ICSs has a strong conviction that it should be involved in primary prevention and puts a lot of time and energy into employment issues because it believes that employment is a route to better health. Others see themselves in the more traditional kind of intermediate tier of managing NHS providers. So there is much more work to be done to get some consistency and clarity around what exactly are the functions of an ICB and how does it execute them.
So my final question, just to round this section off. ICBs have lots of targets. I've asked you about standardisation. My view, personal as it may be, is that there are far too many targets within ICBs. So it means that they've got a sum of money, they are told they can be quite innovative, but they're set quite a lot of targets, which makes them, they can't be as innovative as they want to be. While doing this report, in that area, was there anything that you saw how we could improve in that area with the target? And that would help to shift the money, to be honest.
I mean, that would have required a qualitative piece to go and talk to them and establish exactly what they're doing and why they're doing it, why there is duplication. 8 weeks, we didn't have the time to do that. I hope the NHS plan, it would be obviously part of the themes in the NHS plan, the 10-year plan. And it's a very good question to ask. There's another element to it, is what happened since the creation of these and what happens to them during COVID. During COVID, there were all sorts of changes and roles and responsibilities.
A lot of these targets slipped, Lord Darzi.
Yes, I'm sure.
So it meant lots could happen. And going back to Ben, that has been the problem. The targets have quietly escalated again. Anyway, I'm going to leave it there because I've had my time. Thank you very much. And thank you to the Chair. Thank you.
Thank you very much indeed. So we now come to Danny Beals, please.
Thank you, Chair. And thank you very much both for the exceptional and very helpful report and also for bearing with us today. I know it's been a long session. I think you'll be pleased to, I think we're the penultimate speakers, Greg and myself, questioners, so we're almost there. I'm going to ask you specifically about the productivity issues raised in your report, and I think I'll be focusing on capital spending and on technology. On capital spending, to start with, you tell a really stark situation in the report around very significant capital needs gaps right across the health service, whether it's the acute trusts and secondary care, primary care, community services. So it's almost difficult to know where to start really with this massive and increased financial need for investment. You also talk specifically about how relatively the NHS was performing fairly well in the early 2000s, 2010 period in terms of capital investment relative to Nordic countries in the Euro 15, but that has completely shifted and we've lagged very far behind now those comparators on capital investment. So I wanted to ask you, in terms of prioritising capital investment going forward, did you have any sense with our comparators where that capital investment has gone that we've missed out on relatively, and any impacts that that's had on their relative performance? And secondly, in terms of prioritising where we go forward in capital investment, where you feel the capital investment would have the biggest impact on productivity?
Yeah, I mean, I'll start and Tom will go into the detail. That was certainly for me one of the troublesome component, because you couldn't you couldn't explain really the productivity drops that we were seeing. I mean, as you may know, 17% rise in staff in the last 3 years, and the productivity has crashed. And that's both infrastructure, as you eloquently, and I work in one, St Mary's, where we still have a ward, in the Mint Wing, which was the old Victorian stables. It's a listed building. And always remind, when I was appointed, I would have been part of I don't know how many surgeons we'd have had, but in general cancer surgery would have been about 5 or 6 of us. That's doubled now. We still have the same number of operating theatres. So how we're going to improve productivity it's very obvious. We're trying also to sweat the asset. But what I said earlier, we're waiting for 3 hours in the morning to see whether the patient is admitted. That's another reason. So there is an infrastructure investment, and obviously technology. Look at our MRI scanners, CT scanners. Per population, they're absolutely well below what the average is into many of our comparator countries, and most of them are really, really dated. So servicing them is costly, so diagnostics is absolutely critical. Let alone the IT structure. When you see many of my younger colleagues who are in training, spending about 20 minutes to 30 minutes to just log into the computer to start entering data. That's so disheartening. So we have to do this, and that's the reason why our productivity has it's a significant challenge, and we need to do something about it. More detail from Tom.
Well, the backlog maintenance alone is now nearly £12 billion, and so what's the practical effect of that? Well, services were disrupted at 13 hospitals a day, every day, in 2022. So that gives you a sense of the scale of the disruption caused by these kind of problems, and sometimes it's problems as of the building literally crumbling, so water coming in, flooding a ward, those kind of issues. Then of course there's more sort of problems directly with equipment. So for example, I think I was talking to someone at the Arras Trust, St Mary's, and the MRI scanners are now so old and decrepit that they can't be run for 3 shifts, so they have to be run for 2, and obviously that massively impacts on productivity. You get a 50% increase in productivity with MRI scanners if you could run them for 3 shifts a day rather than for 2 shifts a day. So there are those kind of issues across the service. There's obviously an immediate call for the backlog maintenance that has to be prioritised and dealt with. Then if you take the kind of, had we spent that money, well then the 40 hospitals that have been talked about would have already been delivered. But then there's a bit that gets much less attention just because it's on a smaller scale, but it doesn't mean it's less important. A lot of the primary care estate is absolutely not fit for purpose. It predates the founding of the NHS in many cases. There are plenty of examples of primary care facilities that are not in purpose-built buildings at all. They're not accessible to people with disabilities, so there's a clear call for capital there. And then one area that I think is important to emphasise is also on mental health. So Ara did a visit during the investigation, and you see some of that in the report, into a locked ward, and the conditions were atrocious. And I think there is a particular moral responsibility for people who are detained against their will to be living in a reasonable set of conditions, not least for the fact that for some of these people who are there for quite long periods, that is in fact their home. That's where they're living. That's where their home is. And so having, tiny rooms and 17 people sharing a single shower and problems that can't be resolved with vermin is just, it should be unacceptable to all of us. So I do think there's something about when we think about prioritising capital expenditure, yes, you can look at the big shiny new hospitals and everyone will pay attention to that, but there's a very important obligation to sort out mental health and primary care facilities, many of which are stuck in not just the pre-NHS era, but actually before the 20th century. So I think we've got a lot of work to be done to sort that out.
Thank you. That's very starkly put, the challenges ahead. In terms of addressing them and securing the investment, you also describe quite a dysfunctional system in terms of capital investment allocation. I think you describe it as Byzantine in the approach of how business cases are developed, how the NHS managers approach and are dealt with in terms of kind of capital investment bids, which is certainly something probably my local trust would themselves recognise at Hillingdon Hospital, having waited many years for. I mean, the flooded wards rings very much true. It might have been that exact trust. In terms of in your discussions with stakeholders and kind of elaborating on the kind of Byzantine nature of the process, what specific problems are there with how capital investment is managed, and what reform to that process have people told you would be helpful in addressing those challenges?
Well, I think the first problem is just an insufficiency of the sums of money, right? So there simply isn't enough capital going into the system at the moment. And if you look at the kind of macro problem over time, so the big problem for the health service at the moment is low productivity. So productivity is very significantly down. And in the end, productivity is the sort of name of the game, in that it's what you get out for what you put in. At the moment, in the acute sector, overall productivity is down 14.3% compared to its 2019 baseline. And so that means that, fewer patients are being treated than would have been had we stuck to a pre-existing level of productivity. And capital is crucial to that. So if you reduce your capital investment, you're likely to lower your productivity, because the ratio of labour to capital goes in the wrong direction. And so people are more likely, like if you just said beforehand, if I were to reduce capital intensity and increase the amount of labour, what outcome would I expect? Well, I would probably expect to have lower productivity, because the whole dynamic of capitalism, the clues in the title, is add more capital and then you'll get higher productivity growth. So if you crash capital spending and then you see capital assets deteriorate, it's not then surprising that productivity has fallen by such a significant degree. In terms of the specifics of the process, creating a business case and consulting on it is an unbelievably painful and difficult task. And on top of that, the rules are very different. To take the local authority point, the rules for NHS capital are totally different. So in local authorities, there's much more freedom around capital. In the NHS, the Treasury insists that all receipts return to it, and then it gets redistributed out. So there's very little incentive to dispose of assets that are no longer fit for purpose, partly because the trust that does the disposal will not see the benefit of having done that. So it will go through the pain of the business case process and the consultation, only to find that the receipt that it gets from that asset disposal goes back to the Treasury rather than to the trust. So that's a very sort of tangible example of the problem. But the first problem is there isn't enough. And then the final problem, if you look in the report, I think it's on page 102, you can see that in this environment where there was clearly not enough capital going into the NHS and a very significant accumulated backlog of maintenance, the NHS nonetheless produced a series of very significant capital underspends. So that already tells you that the system isn't working, because if there's a desperate need for capital and the budget isn't being spent, that isn't working. So in practice, in that period, those capital underspends acted as a kind of informal reserve for the Treasury. So by not spending the capital, it meant that those capital budgets could be raided to plug the holes in the unrealistically low spending settlements. And that dynamic, I think, is possibly part of the explanation as to why nobody has fixed the very well known and very well described problems that exist in the NHS capital regime.
Thank you.
Could I also add to that is, which is another piece of work did many years ago in London, there is the NHS estate, the unutilized NHS estate in London that is not unutilised, is 3 times the size of Hyde Park's footprint. So we're sitting a lot of land and infrastructure that we need to start mobilising to even help us. But that's even within the same hospital, by the way. You have a lot of assets that you're not using clinically for whatever reason, but you can't dispense them and generate your own capital, let alone getting capital from the NHS.
Really helpful. I think I have 1 or 2 minutes left. So just turning to technology, and it will have to be brief. Again, kind of stark issues, but what struck me was there are cases of adoption of technology, often quite routine technology, by GP practices that you describe that drive innovation, automated route planning or texting patients to reduce DNA rates, quite simple interventions, but not universally adopted still. So is it a case that we need to chase big shifts in technology, the use of AI you talk about, or would productivity be driven by actually standardised use of quite simple technologies? And why have those adopters, what are the factors behind those that do adopt that others can learn from?
For me, this is quite a, this is all about innovation. Innovation is a pull, it's not a push. And I think, and you see, as you say, the 2 extremes. You see amazing transformative innovation, really transforming the whole pathways of care. That's where you start and you create the pull, whether that is the stroke pathway in London, which we did in 2007, from 32 hospitals into 5 comprehensive stroke centres. It became a Harvard Business School case study. Harvard Business School published it, the NHS at its best, a really reconfiguration of stroke. That was based on innovation, because you wanted a 24/7 imaging done, radiologists available to read it, to put the catheter in, dissolve the clot, and the patient will walk out of the hospital within 48 hours completely without any deficit. That is what we need to aspire for. The 10-year plan will only work if we really drive innovation through it. And it needs to be at every pathway of care, from the cradle to the grave. You ask another question, should be one size fits all? I don't believe so. You have to, you're talking about some intelligent, highly educated people out there. As long as you give them at least the heterogeneity of the different tools available to do what needs to be done. I really, really believe in this, and I think we're not good at this. We have to improve.
And these common purpose technologies, I think you're absolutely right. Getting those applied more consistency would have a big impact. So to give you an example, right? If you imagined, for any of you that use Amazon, that from tomorrow, the way in which Amazon would deliver parcels to you would be that all the parcels would be thrown into the back of the van, and the Amazon delivery driver would get a printout of a list of names and addresses listed alphabetically by your surname, and then said, off you go, do your best. How long do you think it would take to get a package? So every day we send 300,000 or 400,000 people out with a list of names alphabetically and say, do your best, you work it out. You work out which order you see people in. And so as long as we don't adopt even some of these basic technologies around automated route planning, having some of the data to hand, figuring out some of those basic things, we're going to have the NHS persisting in this kind of low productivity equilibrium. But actually, it's not like you need these radical breakthrough technologies that don't exist someplace else. You actually need some of the things that are in common use in other sectors in the economy to be taken into the NHS. And then separately, the potential from new innovations, particularly in AI, are enormously exciting. So passive data capture, for example, where basically AI is able to capture what the clinician is saying to the patient and record it and summarize it, so that instead of the clinician focusing on the computer and data entry whilst they're talking to the patient, they can be looking and speaking to the patient directly, and the system is capturing it. That presents an enormous opportunity to improve productivity in almost every setting of care. So there is something about being able to capture all those opportunities that are really at the sort of technological frontier, but there's also something about making sure that we get some of the basics right that simply don't exist in the NHS.
Greg Stafford.
Thank you very much, and I'm going to ask a couple of questions on productivity, but I just before that want to bring it back to something you said earlier. In response to one of my colleagues, you said, I'm just a surgeon who works in a hospital. Well, that's clearly you are, but you're clearly more than that. You've been a Labour government minister, you've been commissioned by 2 Labour governments to write reports, you're a peer of the realm, and in this report and previously, you have criticised both directly and by essentially implication governments prior to July of this year. So I don't think it's unreasonable to ask you to comment on the current government. So taking it back to a point that was raised by Mr. Robertson, what do you think the current government has got it right, both in terms of overall spending, but also that balance between health and social care? And do you think the current government has the reforming zeal to really enact some of the stuff that you've highlighted in the report?
Could I just correct you a bit there? I've also worked with the Conservative government. You may not be aware of that, but I was appointed by Lord Cameron as his health and innovation ambassador.
Makes it even more important.
Absolutely.
You're able to answer these questions
then. I also chair the Accelerated Access Collaborative as we're talking about the innovation side. So, and I'm independent. So back to your question: is the government fit to deliver what you've done? Absolutely. I mean, the vision is there, the determination is there. The budget announcement was a critical point of it. My interaction with the new Secretary of State started around the time where I was asked to do the NHS investigation, and I was given the whole complete freedom to do this, and I had the access to all the data from the NHS and also a lot of the analytical support that you see in the report. And I think this is, if this was a clinical case, you need to know your facts before you plan the treatment with the patient. That's the way I will approach this. I hope I have given the doctor who's going to fix the NHS the plan or what the problems are, and through the next process of how do we really try to address the significant challenges that are facing us. And by the way, we've done this before, you're correct, and it has worked, and I don't see any reason why it should not work this time.
I hope you're right. Moving on to workforce, clearly staff morale has an impact on productivity, and allowing managers and clinicians to have the autonomy and freedom to be able to do their jobs properly is part of that. How do you see the balance between the clinical leadership and the managerial leadership within the NHS working in order to improve morale and to improve productivity?
Yeah. I think there are a number of other reasons why the morale might be low beside productivity, but that's it. That's in downstream. That's the end point.
If I wasn't clear, it's not that productivity is affecting morale, though I'm sure it is. It's how do we improve morale from a clinical and managerial point of view in order to increase productivity?
I mean, the frustrations are what we've described earlier. The frustration that you come in the morning, I'm talking about a surgical case again, an example, you come to your theatre, you're waiting, there's no patients, you've seen the patient, you've tried to consent the patient is not ready, you're wasting a lot of time. That's not just from a clinical perspective. Obviously, your managerial colleagues are also frustrated by this. They're doing their best from the night before to see who is physically able to be discharged in the morning. I think those two are aligned. They should work again hand in glove, because at the end of the day, clinicians have managerial skills. Managers who are working in the National Health Service also fully understand what the clinical challenges are. So,
the shift, therefore, and I know you were critical of the overall reforms, but the implication or the outcome for the 2012 reforms was to give clinicians more leadership roles. Is that something you approve of, or do you think the separation between clinical and managerial needs to be separate?
Absolutely not. I fought for empowering clinicians at the end of the day to deliver what needs to be done was the right thing. And absolutely, and I agree with you, that was the thesis of the 2012. But what I didn't understand was the major restructuring. That is the distraction that took a number of years.
And it did it on the wrong side, in the sense that what it did was it tried to get GPs involved in commissioning services. So I think the scope and opportunity for more clinical leadership is in the provision of services. What it tries to do was to take GPs away from their provider roles, which is what was so unusual about the 2012 reforms and why no other health system has attempted anything in that direction, and essentially said, look, a set of highly technical planning skills and capabilities should now be taken on by people who've been to medical school is a kind of slightly peculiar thesis, saying that the people who are the frontline clinicians should be leading and managing the services that they themselves have been involved in delivering is a much more reasonable and logical conclusion to arrive at.
Thank you. And then just moving on back to where we started the whole session, which was around data. And obviously the questions at the start were at the macro level about how we look at data to make big decisions across populations. But looking at the data that trusts or ICBs or any of the providers or commissioners look at, what was your assessment of the quality of the data? How can you improve it? How can it be shared better between systems? And do you think there needs to be a lot more investment in clinical coders and coding to ensure that the data is correct at that starting point?
It depends what you're using the data for. What we used it for, it was more than adequate. We looked at a stretch of the data sets, and that's really, we wanted to see trends and what happened. If I am a surgeon in cancer and trying to see on the outcomes of a specific cancer over a period of time, then I would love to have a much more accurate data just to tell me it's cancer, it's what type of cancer, what stage of that cancer, when was the presentation, so you get to get a much granular data to look at very specific outcomes. For example, a stage 1 bowel cancer will have a significantly better outcome, so you'll be surprised if they don't, and you can go and deal with that. We haven't gone into that detail or granularity, but we could do that, by the way. We could and we should be doing that, because that is one of our really strongest, more powerful assets.
Just to push on that, I know you mentioned, I was pleased to see you mention the Getting It Right First Time programme, who I worked for up until becoming a Member of Parliament. But just really to push you on that, do you think the sharing of data at a local level, either within organisations or across organisations, is good enough?
I don't think so. I don't think so, sir. You know that from your roles you've played before. We could do much, much better. And the data is one way of integrating organisations, not just structurally, but data flows could be...
The real-time data that would make the biggest difference. You know, if a patient shows up at A&E, it could be a total mystery as to what medications they've been prescribed in primary care. Yeah. If you could share the data across settings, you could improve the quality and safety of services in a very significant way.
Thank you, that was really helpful.
Thank you. And just to sort of follow up on that, you know, counting things in the community has been a consistent theme through these 2 hours, and thank you for answering so eloquently throughout this time. But what might be the barriers to getting the data from those settings that you've observed?
The community...
Well, the first thing is you just have to choose to count it. So it's as technical and simple as you need to put a flag as to whether a nurse is working in the community setting or working in a hospital setting, or are they working in both, in which case what's the division of their time between the two. So there's something just very technical about, are we flagging in the existing data systems? But the area that is a sort of data desert remains all of care that exists outside of hospitals. So hospital data sets are much, much more advanced than out-of-hospital data sets. And that's partly a reflection that hospital data systems are also much more advanced than systems that exist outside of hospitals.
I was trying to get under the skin of something you said about technology. Is it technology, or is it that, you know, it's culture? The culture of counting doesn't exist.
It's both. One of the reasons that culture is not there is that the hospital trusts got very good at counting things as a result of the introduction of the national tariff, which meant they got paid for activity. If you get your income is dependent on you counting things accurately, not surprisingly, the degree to which you accurately count things increases. Because community and mental health services have been paid largely on block contracts, it's just meant that the data completeness levels have always been much lower, partly because there's not been a significant financial incentive for the data sets to be complete. And if you take the most detailed data that exists in primary care, it's all the data sets that exist around the quality and outcomes framework on which part of GP pay is based. because recording is deliberately financially incentivized. So where you've got financial incentives for data recording, the data sets are pretty complete and much further advanced, and where you have no financial incentives for data, the data sets are much less complete and much less advanced, and so it's fairly clear what drives the disparities in data.
Thank you. I mean, there's a natural tension potentially between counting and quality is, one of the key themes that comes through the report, and indeed
measuring quality is part of that. It's not just measuring activity, right? It's also measuring quality.
That's very important. Thank you. And we've got one question that we hadn't got to at all, which was about pharmacy. Jen Croft, I wondered if you wanted to ask about that before we start to draw to a close.
Thank you, Chair. It was just to touch on, you mentioned that community pharmacy has a key role to play in reducing some of the burden on primary care services. Just sort of how do you see that going forward, and what sort of further more clinical role could potentially community pharmacies play?
Yeah, I mean, firstly, let me start. There is a serious challenge when it comes to pharmacy at the moment. There's a lot of anxiety out there on pharmacies remaining. A lot of these businesses are deciding to shut down or for whatever reason. I think that's something you should look into, because it is of grave concern. I personally, and I'm sure Tom as well, believe that pharmacy could provide significantly greater both health and well-being and healthcare. And it's an opportunity missed, because we're really going to reduce the burden on our general practice and community services. Pharmacy has a huge role to play. And we have seen that during COVID as well. They had a huge role to play. So, yeah.
You want your pharmacist not counting and dispensing pills. Yeah. You want your community pharmacist to be involved in managing complex regimes of medicine. So what you want is a pharmacist who's in an integrated team, who's helping the GP or other clinicians to get the medication right, rather than just making sure that literally the packet is filled correctly. So there's something about how do you, in the future, delineate between the higher skill set that pharmacists have and the more mundane tasks that are still important to get them right, but as more technology gets brought into the sector, more dispensing could be done in an automated way that would free up the pharmacists to work out, what are the nature of the possible drug interactions for somebody who has multiple long-term conditions. And it's striking, as the report showed, that the rate of increase of people with 2 or more long-term conditions is growing at 6.6% a year. So that community pharmacist role in terms of medications management actually is going to become much, much more important than the role of dispensing and selling beauty products, which fundamentally is not a hugely value-adding activity compared to being able to work out how to use medication the correct way to keep a patient as well as possible for as long as possible.
You might not know the answer to this, but is there an appetite in the kind of pharmacy sector to do more health prevention type work?
Yes, and I've had a lot of people lobbying.
And they're very excited about it.
They're excited.
But we need to make it happen.
Very excited.
They're very threatened by whatever recently is happening in terms of pharmacy.
Very good. This comes to the end of our 2 hours. I hope it's flown by for you as it has for us. We could have kept you for another 2 hours and continued with questions. Don't worry, we won't put you through that. Thank you so much for coming. Lord Darzi, Lord Kibasi, your time is very much appreciated, as was the report. We will continue to draw on it, and with permission, we'll continue to be in touch as a committee. We thank you for your time. We thank those who are in the room and those watching. Thank you all.
Thank you, Chair. Thank you all.
Thank you.
Thank you.